in fact, years, I would say. And Dr. Rajendran is very keen to have the best of the faculties in order to mentor our postgraduates. I request our president, Dr. Rajendran, to deliver his welcome address.
Thank you, Dr. Narmada, and most respected our scientific advisor, Dr. Singarvel sir, and President 2024, Dr. Balashankar, the President-elect, Dr. Somasundaram, and Vice President Gopal Subramaniam, and our Dynamic Secretary Narmada, and Treasurer Dr. Rajkumar, and Academic Coordinator Dr. Thirumurugan, other central as well as state EP members. On behalf of IAP TNC, I welcome one and all. And today's program is from KVP Medical College from Trichy, and I welcome Dr. Sivagurunathan. He's an excellent teacher. And I welcome all the faculties. Dr. M.S. Viswanathan is a senior consultant gastroenterologist and as well as pediatrician from Apollo Children's Hospital, Chennai. And I welcome Dr. Mohit, also from Jaipur. He's a well-known, renowned gastroenterologist in India. So on behalf of IAPT, I welcome. And I welcome all the students, postgraduates from various institutions who has joined in Zoom as well as YouTube channel also. It is one of the excellent program. Almost we have started pre the COVID time, and it's running successfully. Almost we have uploaded 300 teaching program in the IAP TNC YouTube channel, and you can visit that website and you can use that teaching program. And once again, I thank one and all for this opportunity. And thank you, Ramara. Thank you.
Yeah, thank you, Rajendran sir. As I request Dr. Singaravelu sir, our academic coordinator, who has been with us in spite of his busy schedule in all the programs, to guide us as well as it will be a very big motivation to our young postgraduates. Dr. Singaravelu sir, over to you.
Thank you, Dr. Narmada, Dynamic Secretary. The most dynamic, respected President, Professor Dr. Rajendran, our academic coordinator, Dr. Thirumurugan, and all the team members of today's involvement, and with our faculties, our own faculty, Professor Dr. M.S.P., my good friend, and our external faculty, Professor Dr. Mohit Vora, needs a special introduction today. And I'm very happy that he accepted.
Thank you, sir. Thank you.
So your voice is breaking, sir.
The way he did activities doing it.
Sir, Singarvel sir, you can switch off your video and you can talk, sir.
And I have been watching him for the past 4 or 5 years. I'm really honored to have both his academic and as well as administrative skills. Sir, thank you for accepting. And as far as this academic program concerned, our Rajendran has curated in such a way as a treasurer, secretary, and as a president. He has been with our IAP and he is more a great academician. And this program is going very well. How I could know now when I'm to all over the country, and people are selling, sir, all our YouTube videos of Tamil Nadu, we are watching, sir. All academic events are so good. Today also I visited 2 institutions in Calcutta. They said, sir, we have seen you in the YouTube. Then I came to know all through our academic programs. Hats off to our team under the leadership of President Rajendran, Thirumurugan, Narmada, and all our past and President elect all. And today our academic, you will enjoy the piece of it. And I wish I don't want to take much time, though because of Mohit, I took more time because I know him, I want to introduce him. Thank you for giving me this opportunity. Over to Dr. Narmada.
Thank you so much, Dr. Singaravelu sir. We are extremely grateful that you could join at this particular time. As we go ahead with the postgraduate program, and we are all ready to hear the academic session, I hand over to Dr. Thirumurugan sir, our academic coordinator, to carry out the proceedings and introduce our moderator for today.
Yeah, thank you, Dr. Narmada. Just a little bit of correction to what President Dr. Rajendran said. We have nearly 800 videos in our YouTube channel, and right now the IAP YouTube channel has got more than 30,000 subscribers. So plenty of programs, videos are available for people to go back. So let me have the honor of introducing both our brilliant faculty for the day. Let me start with our own Dr. MSV. He is a senior consultant pediatric gastroenterologist and hepatologist at Apollo Children's Hospital in Chennai. Of course, he's also a pediatric liver transplant physician. He has done his first CCT from UK, and he has got special training at Birmingham Children's Hospital. Apart from that, he has also completed the pediatric nutrition degree at Royal College. Of course, we all know that he has been a very well renowned speaker all over the world and has been presenting various presenting various papers and giving lectures to all over the world. Actually, he's one of those. He was the past, I think, current secretary, right? I think national secretary of the ISPAGA, and of course, he has been the executive member of CAAP, and one of the very important key members in the country when it comes to any kind of a gastroenterology teaching. You can see Dr. MSV over there. Of course, he's got a lot of publications, so we are really happy to have you here with us, sir. And then I have great honor in welcoming Dr. Mohit Vora from Jaipur for the first time in our amongst us. He is a pediatric gastroenterologist and the director of Sashak Childcare Gastro and Liver Center at Jaipur. He is also the consultant at Nave Imperial Hospital, Hope Vaishali in Jaipur, and he is the current secretary of IAP Jaipur. Of course, he has been someone who has actively contributed for the various IAP modules and has got quite a few publications at both the national and international levels. So to really eminent people or among us to discuss one of those really interesting, probably difficult cases at times. So I'm really thankful to Dr. Sivagurunadan and his postgraduates for coming forward to discuss a very important exam case, which is about jaundice or cholestasis in infancy. So over to the faculty and to the postgraduates.
Thank you, Dr. Thirumurugan. It's excellent introduction. And as Thirumurugan said, now almost 300 postgraduate teaching alone is 300. So what I'm telling you, and as he said, now almost 800 videos going for CME, everything, and the postgraduate teaching case presentation alone is 300 we are having.
That is true. That is true.
It will be really useful for them. Thank you. Thank you.
Thank you. Over to Dr. Viswanathan and Dr. Probably they can start with some comments, and then Dr. Vora before we can start the presentation.
Good evening, everyone. Thank you very much, and thank you, IAP TNC President, Professor Rajendran, Secretary Narmada, Treasurer Rajkumar, and of course the academic coordinator, Dr. Thiru, who's doing a fantastic job, and of course the moderator today, Dr. Sivagurunadan, his team is there. Thank you very much for giving us a nice case, and let us go through that. Mohit, if you want to say anything, please carry on.
That's good evening, one and all, and thank you for giving me this opportunity, especially to Dr. Singarvelu, sir, and everybody who's been involved. I think
Sorry, I forgot to mention our presidential candidate, Dr. Singarvelu is there. He is MSV, but I also MS Vishwanathan. So Dr. M. Singarvelu is our presidential candidate for this coming year. We all have to support him. Thank you.
Yeah, definitely.
Just a minute, Dr. Vishwanathan, because I know Dr. Mohit Vora, he's from Rajasthan, Udaipur, and I know since long him, very sincere, very honest, and a grassroots worker from Rajasthan. So I wish this young person, just like my nephew, my son, a great success in life. He was the organizing secretary of the Pedicon, which was held in Rajasthan recently. So he's a very energetic person. I wish him all the best. Thank you.
Thank you, Dr. Sarin, for your inputs. Thank you. Yes, Mohit, carry on.
Yeah, thank you everybody. Thank you, Sareen sir. Thank you, Sigarvelu sir. Thank you, Vishwanathan sir, and all everybody who's been involved there. So I think without wasting much time, let's come directly to the contents. Over to the two girls students who've been waiting. Over to you, Bita. Please start.
Shiva, நீங்க மியூட் பண்ணிருக்கீங்க. You are muted.
Please unmute yourself.
Shiva, you are muted. Yeah.
Sir, respected dignity. Good evening to all and all present here, sir. Dr. Tendal and Sangeeta, you can start. Thanks for the opportunity, IIP Tamil Nadu branch and MSV sir and our president sir. Thank you, sir. You can start.
Good evening, sir. First of all, I would like to thank IAP for this wonderful opportunity.
Can you please put this full screen, Dr. Ilan Tendal, please?
Sir,
Make it full screen.
Is it full screen? I mean, slideshow.
Just go at the bottom and go to slideshow.
Go down.
There's a little cup-like symbol is there. No, just click on it.
Yes. Go down.
Down.
Still down.
கீழே பார் இருக்கு பாருங்கம்மா. அந்த பாருக்கு பக்கத்துல ஒரு இதுக்கு சிம்பிள் பாருமா. கீழே பார்
yes. இல்ல கீழே தான்.
Here. Third, fourth symbol.
இந்த பக்கம் வாங்க. ரைட்டுக்கு வாங்கம்மா. Yes. சாரி, நீங்க லேப்டாப்ல லாகின் பண்ணிருக்கீங்களா, மொபைல் லாகின் பண்ணிருக்கீங்களா?
laptop.
Okay, then it should be fine. Please carry on.
Share the screen.
Slideshow.
Just hit the F5 key now right at the top.
Yes.
F5 right.
Is it visible, sir?
Click it.
Yeah, F5 key at the top and F1, F2, F3, F4, F5 மட்டும் எடுத்துக்கலாம். அது ஓகே. Right, click on.
Click.
Okay, sir.
Click பண்ணுங்க.
பண்ணிட்டேன், sir.
It's not coming.
You have to click it twice.
Carry on, don't worry, carry on. Just carry on.
Just 1 second.
டாக்டர் திருக்கு நீங்க அனுப்பிச்சிருக்கீங்களா அத இந்த பிபிடியை?
Just 1 second, just
No, sir.
just click on F5, my F5 key.
I clicked, sir. It is not.
F5 ஒண்ணு நடக்கலையா?
Click பண்ணியாச்சு.
Just start again, share again. இல்லைன்னா சிவா சார் அனுப்பிச்சு விட்டுருவோம். Share one. In the meantime, you just share. சிவா, நீங்க ட்ரை பண்றீங்களா? ஷேரிங்.
ரெண்டு கேள்வியும் பாத்தீங்களா?
இல்லப்பா, just when you share, share your whole screen. Don't share just only the PPT. That may be the issue. Just share your whole screen, no? Stop it. Then share your whole screen.
Okay, sir.
And then you go to the PowerPoint presentation mode. It will be okay.
Entire screen தான் இது. Sir, now it's visible.
சரி, ரைட். நீங்க அப்படியே பிரஸ் பண்ணுங்க. அப்படியே பிரஸ் பண்ணிட்டு. Okay, fine.
Yes. Tendal, it's coming.
Okay, go ahead.
Ma, unmute. Yes.
Yeah.
45 days old second born of third degree consanguineous marriage male child hailing from Palakarai, Trichy, whose informant's mother, whose reliability is good, with the chief complaints of yellowish discoloration of eyes, skin, and urine since third day of life. Since the child had complaints from third day of life, I would like to start from the antenatal history. Antenatal history. The age at the marriage was 24 years. She spontaneously conceived this baby at 27 years. The obstetric score was P2L2. She was registered and immunized. Pre-pregnancy weight was 52 and the total weight gain in the pregnancy is 11 kg. First trimester, the pregnancy was identified by urine pregnancy test at 40 days of amenorrhea in nearby PHC and confirmed by USG at 50 days of amenorrhea. She was immunized with 2 doses of TB. No history of fever with rash, post-auricular lymphadenopathy, arthralgia, or genital ulcers. No history of drug intake other than folic acid. No history of excessive vomiting. No history of radiation exposure. Second trimester, felt at 5th month of gestation. Took iron and folic acid tablets regularly. She was diagnosed to have hypertension at 5th month of gestation and prescribed oral medication for the same. No history of GDM or hypothyroidism or anemia or a jaundice complicating pregnancy. No history of any arthritis. Anomaly scan done at 5th month of gestation and said to be normal. Third trimester, there is no history of fever, burning micturition, no history of lower abdominal pain, no history of any foul smelling vaginal discharge or genital ulcers, no history of any bleeding PV, premature rupture of membrane. Growth scan was done at 8th month of gestation and said to be normal. Natal and postnatal history. It was a full-term normal vaginal delivery at 38 weeks of gestation with a birth weight of 2.78 kg at a government hospital. She was tried immediately after birth. He was admitted in NICU for respiratory distress due to meconium-stained liquor immediately after birth. He was given to support for 3 days and given IV antibiotics for 7 days. And the child was said to have icterus on third day of life. The child was taking chemotherapy for 3 days. Direct
one second, please. Dr. Shivakumar, please mute. And if possible, Dr. Shivakumar, please mute. If possible, Dr. Thiru, please mute everyone apart from the speaker. Thank you.
The child was started on DBF on day of life 4. No history of umbilical catheterization, discharge or redness around the umbilicus. No history suggestive of total parental nutrition. Child was on exclusively since birth.
So please, one second. Shiva, can you call Dr. Shivakumar and ask him to mute? Please call him. Please call Dr. Shivakumar and ask him to mute.
Admin can mute all except the speakers.
Carry on.
Who's the host?
Shall I continue, sir?
Please continue, ma. Please continue.
The child passes urine around 7 to 8 times a day and sleeps 2 hours approximately after each feeds. The mother noticed that the baby had high colored urine which stains the diaper at 5th day of life, but she was reassured and discharged on 7th day of life. The child continued to pass high colored urine.
I think one second, please stop here. Please stop here. Yes. So now go back. Just I want to go back. We want to ask few questions here.
Okay,
before sir. Because we have got postgraduates also. I want you to go back to the first slide, the presentation slide. So first slide. Yeah. So you have a baby who's presenting to you at day 30. Just go to the first slide, ma. Please, first slide.
Day 3 of life, sir.
Day 3 of life. And then, no, what is the current baby's age now?
45 days, sir.
45 days. Okay. No, because now people have listened to the history presentation, they've listened to the presenting illness, they've listened to the antenatal history. I know you did say something about the antenatal history. I want to have what sort of particular antenatal history you want to ask pertaining to this your case, and what are the things you are running in your mind.
History suggestive of intrauterine infections like fever with rash, post-auricular lymphadenopathy, and arthralgia. History of
No, I know. Which intrauterine infection you're talking about?
Sir, CMV and HSV, sir, particularly.
Do they present with post-auricular lymphadenopathy? Do you know that?
Sir, rubella is due to post-auricular lymphadenopathy, sir. Genital ulcers is due to hepatitis.
Okay, one by one. Okay, one by one. Okay. So we are talking about the first trimester issues in the antenatal period. Okay. The other things you are talking about?
In second trimester, I would like to ask for jaundice and pruritus history, sir.
Okay, pruritus. What is the idea of asking about pruritus in mother?
If acute intrahepatic cholestasis is present in during pregnancy in the mother, it can lead to PFIC in fetus.
It may be an indication of PFIC. Okay. And anything else particularly in mother you will ask for?
Excessive vomiting.
No, I know, but no, pertaining to the liver disease. Yes, you are asking something. You did say about pruritus. Anything else you want to know about what's happened in the third trimester, something like that?
So burning, micturition, and fever for UTI, sir.
Okay. Anything else? Okay. And HELP syndrome, I heard of HELP.
Yes, sir. HELP syndrome, preeclampsia.
What it stands for?
Sir, hemolysis, elevated liver enzymes, and low platelets, sir.
Very good. So all those things are relevant questions. You should ask that. And apart from the during delivery, anything you want to ask for, particularly in the delivery, you didn't mention earlier, but I want to know during delivery or just, I know.
Face presentation, sir.
1 or 2 weeks before delivery. Anything else?
Sir,
particularly, what I'm talking about, intrapartum, during the peripartum period.
High grade fever.
Yeah. What is this?
Vaginal examination.
Yeah. And then anything else?
Foul smelling liquor.
Yeah. Basically, what I'm trying to ask is whether in history suggestion of herpes. Suggestion of herpes during that particular bit is very important. I know what you're talking about, the first trimester, that is okay. But then we have to ask you, because what we see more and more is the late trimester issues, and the first trimester we see very less of issues due to congenital intrauterine infection for the liver disease nowadays. And you will talk about that. And the first slide you mentioned about high colored urine. What does it indicate?
So high colored urine, which stains the diaper, which means conjugated bilirubinemia, hyperbilirubinemia.
Conjugated bilirubin. Is it water soluble or water not insoluble?
Water soluble, sir. That's why
the reason you are getting it existing in urine, and that is staining the diaper.
Yes, sir.
Okay. Yeah, carry on. 1 second. Mohit, is there anything else you want to ask here?
I think consanguinity, which we have mentioned, is a very important point that should be stressed upon, number one. Number two, recurrent abortions is a very important history which you need to ask, especially whenever you're looking into a congenital, this direct hyperbilirubinemia. So 2 things you should not miss. One is consanguinity, another is recurrent abortions history. Yes, sir. Please go ahead, sir.
Correct. Thank you. Carry on.
Thank you, sir. And the child continued to pass high-colored urine since then, but not associated with pale stools. Again, the mother was reassured by family members. History of abdominal distension for past 10 days, which was gradual in onset and progressive in nature, more in the upper abdomen. No history of vomiting or poor feeding. No history of fever, lethargy. No history of irritability or seizures. No history of crying during micturition. No history of bleeding manifestations.
That's okay. We are listening to that. That's fine. I just want to know. Just remind me what feeding the child is on.
Direct breastfeeding.
Breastfeeding. You mean exclusive breastfed child?
Exclusive breastfeeding, sir.
Okay. But I know that they are exclusive breastfeeding now. Is there any other history you want to ask in this particular child? Because particularly semi-urban village areas, what are sort of
pre-lacteal feeds or extra lacteal feeds?
Like what?
Honey or sugar water.
What goes in your mind when you ask those questions? What goes in your mind?
Sir, it can cause sepsis.
And
Okay,
galactosemia.
that's a good point to start with, actually. Yes. Anything else?
Metabolic disease. Liver disease
Fructosemia.
called
No, slow,
like
slow. Repeat. What did you say? Repeat.
Fructosemia.
You mean fructose intolerance? Okay, carry.
Intolerance.
Yeah. Anything? Okay, fine. Okay, fine. And anything else? Okay. Any other metabolic disease? We'll talk about that later on. Fine. Thank you. Yeah.
Okay.
Carry on.
There is no history of bleeding manifestations, no history of difficulty in breathing, no history of cyanosis, no history of any rashes, no history of
Any rashes? Wait. Rashes. What do you mean by rashes? Any rashes? What sort of rashes you are talking about here?
Sir, purpura due to thrombocytopenia or coagulopathy, and blueberry muffin rash in torch infections, rubella and cytomegalovirus.
Right. And the cyanosis, is it relevant to this case? Cyanosis?
Sir, in Alagili syndrome, the child can present with TOF, so I have asked for cyanosis, sir.
So how you start is, I would like to think about the congenital heart diseases which can be associated with cholestasis, and some of them include, one of the example is Alagil. That's why you should start. Okay, carry on. Very good. Okay, carry on. What is the typical, Alagil you mentioned, TOF. Is there anything else happens in Alagil particularly, which is typical of Alagil congenital heart?
Peripheral pulmonary stenosis.
Okay, is it a cyanotic heart disease?
No, sir. That is
Okay.
not cyanotic heart disease.
Yeah, that's what I'm asking. Okay, carry on. Very good. Okay,
Okay, sir.
next one. Yes.
No
And
history of
delayed passage of meconium. What you're trying to say here? What is the relevance in this particular
meconium
case?
ileus, meconium plug syndrome, or hypothyroidism, cystic
Meconium,
fibrosis.
yeah, cystic fibrosis. That's what you're talking about here. Okay. And any other thing as an association with this one, delayed passage of meconium, because your case is you were saying something about cholestasis to start with.
Hypothyroidism.
Yes. Anything else? Any other association of the delayed passage of meconium with any syndromes and associated with delayed passage of meconium? You did say CF, that's fine. Any other syndromes? Hirschsprung, is it associated with any other? Hirschsprung, is it more common in certain syndromes?
Downs.
Okay, fine. Carry on. Trisomy. Yeah, carry on. Very good. Okay, next one.
There is no history of.
No, go back. One important. Native treatment. What is got a relevance of native treatment to this particular case?
Sir, our people will tend to have a native treatment for jaundice, sir. So,
Like what? Any particular relevance of our Tamil Nadu native
sunlight exposure in this age of sunlight exposure and some leaf.
Yeah, okay, we'll come back to that. Okay, fine, carry on. Okay, one second, wait. Mohit, is there anything else you want to add here, Mohit, please?
Inspissated bile syndrome also you need to keep in mind.
Okay.
Inspissated bile syndrome, that's another, that's another entity which, please go ahead.
Carry on.
Developmental history. He alerts to sound, social smile attained, immunization history, OPV, BCG, and hepatitis B were given at birth. There is no history of bleeding during injections. Family history. There is no history of any similar illness in the family members. There is no history of sibling death.
And as Dr. Mohit mentioned, you can also mention here any history of abortions, again, any history of apart from liver disease, seeds you mentioned, that's also again very important here. Okay, carry on. And here, I know that you mentioned, you have to mention the consanguinity here also.
So that is
the consanguinity here. Huh?
Third degree consanguinous.
Thank you.
Okay. Socioeconomic history. He belongs to lower middle class according to modified Kusami scale. Summary. 45 days old second born male child of third degree consanguineous marriage who was a term baby with a normal birth weight, admitted in NICU for respiratory distress and jaundice, now presented with jaundice and high colored urine which stains the diaper, and abdominal distension for the past 10 days with pigmented stools and good weight gain. So it is suggestive of hepatobiliary system involvement, probably due to neonatal cholestasis syndrome. So I'd like to proceed with the abdominal examination, sir.
Mohit, is there anything you want to start?
So what on the summary are the pointers which are suggesting in favor of a metabolic liver disease till now?
So the child is having only high-colored stools without any pale stools, sir. High-colored urine without pale stools, sir.
But that suggests your your conjugated hyperbilirubinemia.
Conjugated hyperbilirubinemia.
What are the pointers in the history whenever you are going for a say neonatal cholestasis, which will suggest that there can be involvement of a metabolic disease or metabolic disease is the cause. What are those pointers in the history you need to look into? That's what I'm asking.
So
Even in
natal,
this case and in general also.
sir, natal history we have to look for it is whether it is a preterm or IUGR baby,
Right. Very
and
good.
birth weight and fair that if there is very good adequate weight gain is there or not.
Adequate weight gain is not concerned with metabolic. Okay,
And
go ahead. What other?
consanguinity,
Right. Besides
then
that,
Fatty liver of pregnancy and the preeclampsia. So pruritus.
one
pruritus in mother,
you said is a prematurity, right?
Yes, sir.
That is one. Then
male
what,
child is more of
what else in your history do you think? Is there any metabolic pointer which is marking towards this? So consanguinity is another point which is
okay, sir.
important. Need to keep in metabolic disorders, right? What else?
Only high colored urine and
Okay, chalo, go ahead. We'll discuss everything when we'll discuss the approach. Okay. So
The
go ahead.
question Dr. Mohit is asking is, anything in your history so far which is suggesting of metabolic disease? This eye-colored urine just says there's a congenital hyperbilirubinemia. It doesn't tell you whether this is towards metabolic liver disease. Okay. And the pigmentous stools, there's a history, but we have not yet seen it. We have to see that. Then we'll talk about that. Okay. So anything
the
else?
child is not sick, like the child is stable,
Well thriving child.
So you are saying it is favoring metabolic disease or it's not favoring metabolic liver disease?
actually it is as per history it is not favoring metabolic disease.
Because the child is not sick.
Yes,
Does
sir.
all metabolic liver disease in this
No,
age
sir, it is
present with so I think you're right. What the word you should use is, if it's a metabolic liver disease, probably the child would have some of the common metabolic disease. I would have expected the child to present in a much more in a sick way.
Yes,
This
sir.
child doesn't seem to be the case. But what I'm saying is that's the way saying in a way like that. Okay, we'll come back to that again. And another thing is, did you say you told the weight? Sir, I know you'll come. You will say the weight later on. That's fine. And do you think the child's weight is okay now? What do you
Yes,
think?
sir. Yes, sir.
What is the weight?
4 kg, sir.
4 kg. And you think it's okay? What was the birth weight?
2.7, sir.
Do you think this weight in this particular child, 4 kilo, do you think it is this baby's correct weight, or do you think are you satisfied with this weight of 4 kilo? Do you think this 4 kilo means the child is weight is fine? Do you think that?
So the child was admitted in NICU for 7 days, sir. So the discharge weight could be 2.6 around. The child is now 4 kg, sir, 45 days old. I think
What I'm trying to ask is, in the context of a colitis baby, could it be something else which could contribute to this weight?
Eddie.
No, I mean, the baby might be nutritionally appropriate and 4 kilo, or it could be due to something else adding to this weight, and that's the reason why the baby is 4 kilo. What could be that?
Edema
Or
hepatomegaly.
Or hepatomegaly or splenomegaly or distension.
Organomegaly.
All these things. So just because I know that we say that, just because there's a baby, is a well-looking baby, weight is okay, doesn't mean that this is nutritionally appropriate baby.
Okay.
It could be, or it could be due to something else, falsely making the weight, in the normal range. You get what I'm trying to say?
Okay, sir.
So you should be open-minded. Okay, carry on. Yeah, carry on.
Okay. General examination. The child is alert, active, and afebrile. No respiratory distress, no pallor. Icterus was present. No cyanosis or presacral edema. Vitals. Heart rate was 140 per minute, regular in rhythm, normal volume. Felt in all peripheral vessels equally on both sides. Respiratory rate 30 per minute. Abdominothoracic type of respiration. Temperature is normal. Blood pressure is 80/60 in right upper limb. Forelimb saturation was normal.
As part of your examination, go back. As part of your examination, in the general examination, when you feel the pulse, when you feel it's felt in both sides very well, which particular pulse you look for?
Femoral.
In this age group, that's the best thing to look for. It won't be easy otherwise. So the femoral pulse are very well. Usually we are not that much worried. Thank you. Yeah, carry on.
Head to foot examination. The head size is normal, no microcephaly or macrocephaly. Anterior fontanel 2 cross 2 centimeter in size and posterior fontanel closed. Eyes, icterus was present, no cataract. Nose, ears and mouth normal. Yellowish oral mucosa was there. No dysmorphic faces. Chest is normal, abdomen is distended. Limbs normal, back and spine normal. Genitalia is normal. Skin, there is no rashes. One icterus was present.
Wait. Go back. Mohit, is there anything else you want to ask here? Mohit?
Yeah, let's complete them, so then we'll discuss, I think, probably.
Okay, fine.
Yeah.
So here I want to ask you, you said no dysmorphic faces, and what sort of dysmorphic faces you are looking for?
Sir, in Alagili syndrome, the child will have broad forehead, deep-seated eyes, no pointed chin, and triangular faces, sir.
Okay, very good. Any other dysmorphic faces?
Zellweger syndrome and Down syndrome, hypothyroidism, coarse features will be there.
Okay, fine, good. That's fine. And this posterior frontal, when does it close?
Sir, 6 to 8 weeks, sir.
So this is closed normally here, is it right? And
Yes,
anything else you are looking in the limbs, spine, limbs, anything particularly you're looking for in the limbs?
Edema, sir. Lymphedema will be there.
Where it will be there?
A lower limb edema will be there in Agnew syndrome.
Okay, anything else?
Sir, in eyes, we have to look for posterior embryo toxin.
Well, can you see by naked eye? Eyes?
Sir,
No, I'm talking about the limbs. No, I'll come to that. Limbs. I want to focus on limbs. You did mention about the lymphedema. Anything else in the limbs?
Edema.
Have you heard something called ARC syndrome?
Sir,
ARC.
arthrogryposis, renal dysfunction, and cholesterol.
They may have contractions. They may, not necessary. They may have. Okay. They may have. It's a spectrum. Okay. And microcephaly. Or any relevance here? Microcephaly.
Intrauterine infections.
When do you?
Infections, rubella and cytomegalovirus will have microcephaly.
Okay. Fine. And any macrocephaly and cholestasis, any relevance?
Toxoplasmosis can have macrocephaly, sir.
Why? How?
It will cause hydrocephalus.
Okay. Fine. And eyes, you mentioned about certain features. What are the features you mentioned?
Sir, cataract, posterior embryo toxin, corneal opacity.
Just mention where do you come across posterior embryo toxin? Which condition?
In Alagili syndrome, we have posterior embryo toxins.
And then what else?
Cataract will be present in galactosemia, congenital rubella.
Okay. Anything else? Any other eye findings you mentioned?
And subconjunctival hemorrhage will be seen in coagulopathies.
Okay. Anything else?
Corneal opacity will be seen in Zellweger syndrome, sir.
So early? Okay, fine. Carry on. No problem. Good. And once again, genitalia. Any relevance of genitalia examination? Because
in hypopituitarism, the child will have a micropenis, sir.
Okay. So what else you look for in hypopituitarism?
Midline defect.
Like?
Cleft palate and cleft lip.
Anything else?
Crowded
Immature faces.
What faces?
Crowded.
Immature.
Okay. And you mentioned about skin icterus. Anything else you look for? Not in this child. If I have a child presenting on 5 or 6 months, anything else you look for in the skin apart from icterus?
Excoriation marks will be there.
Like, what do you mean by excoriation?
So due to itching, the child will scratch.
Very good. Thank you. Carry on the next slide. Yes, carry on.
Anthropometry. Weight is 4 kg. Interpretation is at -2 standard deviation according to WHO chart. Length is less than 55 centimeter. Head circumference is 38 centimeter between 0 to -2 standard deviation. Chest circumference is 36 centimeter.
Why chest circumference?
Sir, in general, we have
I know you do check height, you do check weight, length, I can head circumference relevant. I know chest circumference. Why?
Up to 1 year.
Up to?
1 year.
You may know the answer. I'm just because I'm asking doesn't mean that is a wrong thing to do. It could be right, but I just want to know from you why you did it. Because when you present
1 year,
something
the child will have head circumference will be more than chest circumference.
in where?
Sir, at birth, head circumference
Okay,
is...
you have to read that. Okay, next slide. Carry on.
Okay,
So
sir.
what is your inference till now based on this anthropometric examination? What is your inference based on anthropometric examination? What do you think the baby will doing
The child is not
physically?
having any microcephaly. The child's weight is in good.
At 3 months, 4 kgs, 45 days, 4 kg. Okay. 45 days, right.
Yes, sir.
So he's growing well.
Yes, sir.
Okay, right. Even the length. No?
Length is also normal.
Fine, go ahead. Yeah.
Abdominal examination, inspection, oral cavity is normal. Abdomen is distended. Umbilicus is in normal shape and position. All quadrants moves equally with the respiration. Flanks are free. No visible peristalsis or pulsations. No dilated veins or scars. External genitalia normal. Hernial orifices were free.
And
Palpation.
then, 1 second, go back. The distensions of abdomen. What are the things which can distend the abdomen in this age group?
Fluid. Or ascites or organomegaly.
Yeah.
Why not only gaseous distension? Gaseous is quite common. Gaseous distension is quite common at this age. Why not?
Yes,
Yeah, the most common, the baby comes in with OPT crying, they have a gaseous distension at this age, 45 days, 50 days. Right.
yes, sir.
So that, as Dr. Mohit said, gastric doesn't think about it. And then organomegaly probably in this age. Then you think about fluid. Now, fluid, yes, you can think about, but more commonly think about organomegaly before they think about the gastric distension itself. Okay.
Okay, sir.
And anything else in this case, cholestasis, we did discuss about that. Anything else which could cause?
Feces and constipation can cause.
Why?
Meconium ileus, like.
Okay, and okay, carry on. Good. Okay, fine. And do you expect to see dilated veins in this age group?
No, sir. Prominent veins can be there if ascites is big. No, sir. Severe ascites is there. Prominent veins can be seen, but
Okay.
not dilated veins.
Okay, carry on. Thank you.
Palpation. The abdomen is soft, not warm, not tender. Liver is palpable 7 cm below the right costal margin. Firm in consistency. Smooth surface. Well-defined sharp margin. Not tender. Spleen is palpable 1.5 cm below the left costal margin. Not tender. Soft, firm in consistency. No other organomegaly. Abdominal circumference was 43 cm. And percussion, liver span is 11 cm. Resonance heard over the flanks. Auscultation, bowel sounds present, no bruit. Other system examination, CVS, first and second heart sound heard in the left side, no murmur. Bilateral air entry present, no added sounds. In CNS, no focal neurological deficit. Bilateral pupil equally reacting to light. Diagnosis, it is a case of neonatal cholestasis, probably due to neonatal hepatitis. At this point of time, I would like to give a differential diagnosis, sir.
No, before going to a differential diagnosis, just stick to this line. Go back to your diagnosis, what you've made. Only this line, a case of neonatal cholestasis, probably due to neonatal hepatitis. Explain this line, each word.
Okay,
How
sir.
you will justify that this is a case of a neonatal cholestasis based on the history and then based on the examination? And why do you make a conclusion that it is a neonatal hepatitis? Go ahead.
The child is having high colored urine which stains the diaper since third day of life.
So that's a red flag sign, right?
Yes, sir.
But inconclusive stools.
The child,
Inconclusive stools?
yes, sir. The child is having pigmented stools.
Right. So would you still like to call it a neonatal cholestasis just based on the urine it is staining diaper and with the pigmented stools?
And there is hepatomegaly, hepatosplenomegaly, sir.
That's by on examination you're saying. Any relevant history pointers which suggest that it is neonatal cholestasis? Only on one thing, that is staining diaper. You call it what, at what age does it, how many days of life it starts staining the diaper? When the baby is born, initially the even the first urine will stain the diaper. Is it the third urine? It is a 10th urine or a third day or a fifth day?
So,
When does exactly the baby's urine start staining the diaper?
mother noticed on sixth day of life, sir.
So normally when the baby is born, even when did you think this everything started occurring in this baby? When the baby was in the womb, the fetus, or is it after birth?
It is before birth.
Before birth. So even the first urine you are going to expect that it's going to stain diaper. Is it the way?
No, sir.
So initially the urine which comes is a transparent. Please remember that.
Yes, sir.
Right? It is only after 2 days, 3 days. It's up to 72 hours that the urine
child
starts
is-
staining the diaper, which is a very important point to be remembered. Okay. So
Yes.
many a times when I hear the history, people say that the staining of diapers since birth.
Okay.
That should not be there. Okay. You should know the exact physiology. Right. So what do you think is happening in the fetus when there is hepatitis? What exactly is going on? There's an inflammation. There's an inflammation, right?
Yes, sir.
Inflammation of
Liver hepatocytes.
the hepatocytes and the duct
Biliary tract.
and the biliary tract, right? So you think it is a neonatal cholestasis just based on one point, which is your staining of diaper. That's that. Anything else? There are multiple things in your history. Why are you saying that this is a neonatal cholestasis? First of all,
Sir, the child is having high colored urine for the more than 14 days.
more than 14 days, this is persistence of a high colored urine.
Persistent, yes, sir.
Okay. Okay, go ahead then. Why? Probably due to neonatal hepatitis.
The child is having pigmented stools, sir.
So it is basically on the urine in the stool you are making this diagnosis. That's that.
No, sir. No, sir.
Then
Um, the child is having abdominal distension and hepatosplenomegaly.
would you like to keep a probability that mother must have missed the color of a stool? You calling it a pigmented because the mother is not aware exactly of a pigmented stool. Maybe it is a pale stool, but she's not able to decipher it correctly.
Sir,
If that is the case, then
we have done naked eye examination for 3 days, consecutive 3 days. Sir. It
Early
was
morning.
only yellow, sir.
okay, right, fine. So why due to neonatal hepatitis? Why not anything else? Why not? Whether this is a extrahepatic or an intrahepatic, you're thinking? Because
Intrahepatic.
whenever you're looking at the case of a say neonatal cholestasis, you have to keep a diagnosis in your mind whether I'm approaching it extrahepatic or intrahepatic, right? So
Yes,
this
sir.
is your
Intrahepatic.
intrahepatic. Now, when you talk about an intrahepatic cause, what all differential diagnosis you have in your mind?
Bile acid synthetic defect, bile acid transport defect, metabolic
How
causes.
common bile acid synthetic and transport defects have you seen?
Sir,
It's very rare. So,
It's very rare. What is the common?
metabolic disorders.
Metabolic disorders. And out of the metabolic disorders, which are the commonest?
Sir, tyrosinemia,
Hmm.
galactosemia. Yeah, in this child, it is not
No
galactosemia.
issue, not in this child. In general, what is the approach? What all you need to keep in your mind? I'm saying. What all
Tyrosinemia,
intrahepatic? Hmm.
sir, galactosemia,
hereditary
hereditary fructose intolerance.
Right. So the approach should be very clear. Whenever you're thinking about intrahepatic causes, the first should be your sepsis, which you have ruled out, right?
Yes, sir.
And if you're talking sepsis, what organism you're talking? Which is the most common organism causing sepsis?
So, UTI and
Organism.
torch infections.
It's E. coli, hai
E.
na?
coli.
E. coli is the most common organism
E.
when,
coli.
when we are talking about sepsis, right? Then we come to your torch infections. Then we are talking about your, hepatitis B, C, and your CMVs and your other viruses. Okay, what is another more common cause in a sick baby, preterm baby who's been admitted in NICU, being an intrahepatic cause of neonatal cholestasis?
Sick
What
child.
is that cause? What is the cause? TPN.
Yeah.
TPN induced is again a very common cause. What
Yes.
we see, observe in our, right? Also, you have to, as sir was asking, Vishwanathan sir was asking you about the abnormal faces or something else. Why? Because even the chromosomal disorders you need to keep in mind. That's also another intrahepatic cause, whether it's say trisomy 21 or 18 and all these things. What other intrahepatic cause you need to keep?
GALD.
GALD, right? What is GALD?
Gestational
What
alloimmune
happens? What
disease.
happens in GALD?
That is an antibody against fetal
It is an
hepatocyte.
IgG antibody that crosses from
Maternal
mother to
antibody.
fetus and causes the membrane attack complex in the mother.
Yes.
Okay, so that's one. But before that, you need to keep endocrine disorders like hypothyroidism,
And
hypopituitarism all in
hypopituitarism.
mind because GALD and all they are rare.
Yes,
So
sir.
this is how you approach a child whenever you're talking about the neonatal intrahepatic causes. Yeah, in child. That is important. Then you come to the metabolic causes, what you were saying. Look at the carbohydrate metabolism like galactosemia or fructose intolerance, which you have already talked about. Even your GSD type 4 is
Yes.
also important, which you need to keep in mind. Tyrosinemia, I have seen myself 3-4 cases till now, not much, but yes, it is important. What is that indicator in tyrosinemia, which tells that this is tyrosinemia?
AFP will be elevated.
Urine succinyl acetone will be elevated.
Yeah, so first you do alpha fetoproteins. If they're elevated, you are supposed to do a
Succinyl.
urine succinyl acetone, right? That is Niemann-Pick also you need to keep in mind. Then you were talking about the paroxysmal like your Zellwegers and all, right? And what about the other intrahepatic causes? Because you're saying this is an intrahepatic cause, what are the intrahepatic causes? Alpha 1
Alpha 1 antitrypsin deficiency.
absolutely, and the PFIC.
Okay.
Okay, so this is all about your intrahepatic. Yes. So which intrahepatic cause this is due to neonatal hepatitis? Which neonatal hepatitis? What
Sir?
is the cause here? What are you expecting?
Sir? Pardon, sir?
What is the cause of a neonatal hepatitis here?
Here it could be a metabolic cause.
Depending upon your history till now, because this is history and examination you have finished, right?
Yes, sir.
Depending upon that, what are the pointers which suggest that this is because we have ruled out that this is definitely not the extrahepatic one,
Yes, sir.
right? You have
Yes,
said
sir.
the line you have catching hold is that pigmented stools. Fine.
Yes,
So
sir.
that is not an extrahepatic cause. Got it. The child is doing well, fine. Now you say that it is neonatal hepatitis. So what all is there in the favor from your history and examination suggesting what kind of a neonatal hepatitis you are looking into?
The child is not having poor feeding or lethargy or fever. So it rules out sepsis, sir.
No abnormal faces.
Sir?
No abnormal faces, no
No
abnormal,
Yes, sir.
specific
No
cases.
abnormal faces. So
right? So it rules out what else?
Syndromic
Syndromic,
causes.
Syndromic features. Okay. Then
then the child is not having midline defects or higher coarse features. So it
right,
rules out endocrine causes.
right, right. So what are you left with then?
Sir?
What are you left with?
Metabolic causes.
Metabolic. So go ahead. Go ahead. Up to Sir Vishwanath.
Now,
Yeah.
Ilandandal, just go back to your abdominal examination. Just go back.
Okay.
Abdomen. Yeah. So here, yeah, very good. Here, inspection. Here, actually, you have to put it here, stool seen by you, stool examination done. I know that pigmented stools, but you have to put it here, stool seen. I know you have said that, but you have to put it here because in neonatal cholestasis, stool examination is very important. You know that. You put it here, we know that we just not relied only on the history. You have also seen, and if you document, we know that for sure you have done it. That's important. Okay. And next thing is when you're going to go to your slide, go to your last slide, the neonatal hepatitis. What I'm saying is, you just say this is a likely case of neonatal cholestasis, and you have to say non-obstructive, non-obstructive, because we are more worried about whether this is an
Obstructive cause.
We are very worried about it.
Yes,
This is unlikely to be an obstructive cause because the ST is there and we have seen the pigmented stools. So this is unlikely to be an obstructive cause. This is an non-obstructive cause. In the non-obstructive, whether this is a parenchymal disease or due to the biles of the genetic causes or metabolic, then we'll talk about that. So when you say that, we just put points for, points against, so that we know that exactly what's going on in your mind. Okay, that's okay. Go to the next slide.
Investigations.
Carry on.
Basic investigations like CBC, CRP, chest X-ray, LFT with coagulation profile, SGO, including XGOT, PT and ALP, GGT, blood culture and urine culture, naked eye stool examination, fasting ultrasound abdomen, thyroid profile.
One
Specific
second, go back. Then you will be talking about it. When you mean coagulation profile, what you are talking about here? Coagulation profile, what do you mean by
PT, APT and INR, sir.
And 1 second, what is PT? What is INR?
Prothrombin time is PT, sir.
And what is INR? Are they different or the same?
PT INR is same.
Same. So which is relevant to this particular case? For relevance to your particular case, is PT, APTT, which is relevant to your case? Are we talking about bleeding diathesis here? No, we are talking about a liver issue here. So most important thing for me is prothrombin time. When you do prothrombin time, they will compare against the control, they will give a INR. It is international normalized ratio. That is what INR stands for. They compare your patient's PT, the control PT, and they will give that range. Okay. So APT is not relevant for me. Suppose if you are working in an hospital where you have to focus examination test, that's what is relevant to you. And then here, when you mean you put SGOT, SGPT, ALP, GGT, something is missing here. Very important thing is missing.
Bilirubin.
Yeah, what bilirubin?
Conjugated and unconjugated bilirubin.
Total. And then anything else missing here?
Albumin, sir.
Yeah, what is the relevance of albumin?
Synthetic function of the liver is
affected in case of liver failure.
In this particular baby, which is likely to be, albumin will be affected, do you think, in this particular baby?
No, sir.
Why?
There is no edema, sir.
There is no signs and symptoms of suggestive
Don't
of
have to have edema. Don't have to have edema in all cases of hypoalbuminemia.
Okay,
What I'm trying to ask is, this child is 45 days old. And usually there should be some chronicity there. This is very less likely. But having said that, even if progressive liver disease can have hypoalbuminemia in this even particular baby, but unlikely. In this time, prothrombin time is got a relevance. If it is affected, what does it tell you?
Vitamin K is.
No, listen. The
liver failure, sir, and
prothrombin is high. It says liver failure. When it is significant, when do you say it's significant?
PT more than 1.
More than 1. In this age group, no, not necessary. In this age group, sometimes even some babies can have even up to 1.5. 1.5, okay. I mean, up to 1.5 is fine. Okay. Definitely more than 2 is definitely abnormal. Okay. And chest X-ray, why chest X-ray?
So look for associated heart defect.
Any cardiomegaly or hepatomegaly or gallstones.
I do not want to put the word basic investigation here. Okay, this is not basic. This is relevant to this one. Okay, yeah, blood culture, urine culture. You told me. I think definitely urine culture is very important. Do not miss an UTI in a child with jaundice. Thank you.
Thank you. Specific tests.
No, go back. Ultrasound.
Yes.
What do you mean by fasting? How long you want to fast the baby?
4 hours, sir.
Okay, with the babies with metabolic liver disease, will they withstand 4 hours fasting?
Sir, by the time we have to put IV fluids.
Okay, fine, no problem. Good. Okay, so what I'm trying to ask is, what things you are looking in ultrasound?
Sir, gallbladder size and activity of the gallbladder and liver echo texture.
Tell me more about the gallbladder. What you are trying to say, gallbladder?
Atretic gallbladder or non-visualization of the gallbladder or non-visualization of the common bile duct.
So what does it tell you?
Sir, if it's visualized now, we ruled out biliary atresia, sir.
Okay, fine. And anything else you look in ultrasound? Anything else you look in ultrasound?
Echo texture of the liver, sir.
And then anything else?
Other organomegaly like renomegaly or ascites.
And spleen also.
Spleen, okay.
Anything else you look in the CBD? Anything else you look for in CBD?
Gallstones or
triangular cords.
That is for biliary atresia. Very good. Okay. Anything else in the CBD you want to look at an obstetric cause? Anything else apart from biliary atresia?
gallstones or Choledochal cyst.
Choledochal cyst. We're talking about choledochal cyst. Okay. Yeah, biliary atresia and choledochal cyst. Look at the spleen, look at the liver, and also look at the any fluid there. Anything else you look for in the ultrasound? In cholestasis, anything, any other clue we'll get in ultrasound?
Sir, altered liver echo picture.
Okay, that is there. We have talked about.
Periportal edema.
Okay, anything else?
Um,
If there is a situs inversus,
Yes, sir, situs inversus.
you think about that. Okay,
Okay.
fine, carry on.
Why 4-hour fasting?
Sir, in fasting state, the gallbladder will be prominent.
It will be distended. Distended. It will be distended.
Yes, sir, distended.
It will be distended, so it can be easily visualized.
Easily,
Otherwise, because of the overshadowing of the gas, it can be missed. Right? So if the gallbladder is partially visible, can it be biliary atresia?
Sir, if the size is less than 1.9 centimeter.
What is less than 9? 1.9?
Gallbladder size.
The size of the gallbladder is less than 1.9 millimeter, then it is
biliary atresia.
Okay, right. And why is it? It's called a triangular sign. What is this?
Sir, there is a echogenic foci in the right and anterior wall of the portal, right portal.
Right?
More than 4 millimeters. More than 4 mm.
More than 4 millimeters. What is the echogenic sign? What does it represent? Why is that echogenic sign is there? What is the reason for this echogenicity which is being seen?
Sir,
what happens? We are talking about extrahepatic biliary atresia, right?
Bile duct will be.
What happens in extrahepatic biliary atresia?
There will be paucity of bile ducts.
There's an inflammation of the extrahepatic bile duct, not the paucity. There's an extrahepatic. There's an inflammation. What does this inflammation causes?
Biliary injury and
fibrosis in atresia. So this gradual fibrosis leads to the atretic segment. Okay, so that atretic segment, which is the elastic segment, that presents as this echogenic shadow, and this is between the bifurcation of a portal vein, which is called a triangular. Sometimes this extends to the interior wall of the portal vein as well. So there also you need to note. So these are very important subtle signs, because it is very simple when you're saying there, but when you get a ultrasound report in your hand, you get confused. What to do now? Because that should be very clear. You should convey to the radiologist that what you want to look into it. That is also very important. So they say that common bile duct is visible, gallbladder is partially visible. Sometimes they don't use the size. They don't write the size, and then you confused what exactly it is. Right? So go ahead. Yeah.
Specific investigations like TAR screening, alpha fetoprotein, serum ferritin, serum ammonia, enzyme assay, urine succinyl acetone, serum bile acids, serum citrulline level, genetic study, and liver biopsy.
1 second. Before, what are the basic metabolic tests you do before you jump into doing all the succinyl acetone bile? Before you do all the citrulline, what are the basic metabolic tests which you can do in any peripheral hospital? Basic things. What things you can do?
GGT and alpha fetoprotein.
No, that is for one particular group of disease.
Yes, sir.
What particular disease you're talking about? Overall, if you suspect metabolic liver disease, what are the basic things first initially you have to do before you jump and do anything else?
Urine metabolic screening, sir.
That is also a special test that won't be done in your lab sometimes. That won't be. What are the basic things which can be done?
CBG and ABG.
So you remember this word GALAC? You know this GALAC?
Yeah. Yes,
glucose.
Sir.
Glucose. No, the fasting sugar is very important. Okay, glucose, and then your ammonia, lactate, ABG, and urine ketone.
ABG
Understand?
and urine.
That is very important. That gives some clue. Then you go in a different direction appropriately. Okay. And alpha fetoprotein. What's the problem of alpha fetoprotein in this age?
It will be elevated in liver injury.
No, what I'm asking is, I check your alpha fetoprotein. I check a baby's alpha fetoprotein, 45 days old baby. What is the difference? Will it be the same, or what do you think?
It will be increased in children.
what happens, some of the labs, they don't give the range. There is a normogram available for alpha fetoprotein. Alpha protein will be normally will be very high at birth, and then it slowly, gradually comes down. And then it comes to near normal value around 6 to 8 months of age. So
Okay.
even in this age group, compared to the alpha fetoprotein will be high. That doesn't mean that you jump on to think about tyrosinemia.
Okay, sir.
So you have
Okay.
to look at the normogram. That's very important. Okay, fine. And what's the relevance of yeah, I'll talk about I'm going to talk to you about the investigation, the etiology and all in my talk. I will talk about that. That's fine. Is Mohit wants to say anything now?
Fine, I think let him go ahead.
Yeah. So that so I think in your case, hopefully you've done the investigations. Am I right?
Yes, sir.
So what? Just tell in a nutshell what sort of positives you had.
The child has mild anemia, like the 8.9, sir.
Okay.
And CRP was negative, blood culture and urine culture were negative.
Okay.
OTPT were increased, like
Try
around
to, try
600.
to try to use the word AST and ALT. That is accepted
Okay.
terminology nowadays. Okay.
Okay, sir.
Carry on.
ALP is normal and GGT is also normal, sir.
Okay.
In
Fine.
fasting ultrasound, the gallbladder was
But
visualized.
not given many important parameter I want to know. I told you that's the important parameter I want to know.
Bilirubin, direct bilirubin was 12, sir.
And the total is?
Total is 14.3.
Okay. And anything else important and any other investigations?
Albumin is normal, sir.
Anything else?
8PT APTT is also normal, sir.
No,
Put up
just
the slide. Put up
don't
the
bother
slide.
about APTT. I'm not
Sorry,
in
sir.
APTT
PT
at
is
all. Unless
normal.
I'm going to do some invasive procedure. I am interested only in PT. Don't
PT
waste your
normal.
money. I'm telling everyone, don't waste your money in checking APTT for
Okay.
liver disease. Just check prothrombin time and INR. APTT, I will check only if I'm going to do some procedures, some surgeries. I just want to know whether it has a bleed. APTT will not give me a clue about liver. I'm more interested in PT. What's the
PT.
PT?
Prothrombin time was normal, sir.
Okay. What is the normal? What is the value? Do you remember?
Uh,
Okay,
I
leave.
don't remember.
Thyroid test. So
16.2.
what else? What was the etiological? What did you get? Anything else relevant? Any positive investigation you got it?
Sir, alpha fetoprotein was very high, sir. 3 lakhs, around
Okay,
3 lakhs, sir.
very good. Then
And TART screening, IgG, CMV, and HSV is positive, sir.
IgG positive HSV?
HSV.
Any IgM positive?
No, sir.
No, just close it. Okay, next. Anything else?
And we have sent it for a genetic study, sir.
No, did you do any urine succinyl acetone? You told
Yes,
this
sir.
alpha
It's
fetoprotein
negative.
high.
It is negative, sir.
Okay, so one important test you do in this surgery, which you have not mentioned so far. Go back to your first slide because I want you to mention this one. You have mentioned all these ones. Dr. Mohit mentioned about metabolic liver diseases. What are the common metabolic diseases you should not miss at your side before you refer?
Galactosemia.
So what test you should have done?
RBC galt. So the child is
Okay.
not having vomiting and.
Listen. Everybody will not present everything. Okay.
Okay.
But you need to think about it. What are the common tests you can do in a primary care or secondary care hospital before sending for this Galliput? Galliput, not every lab does it. Okay. Tell me what test you can do it.
Ophthalmic examination.
Okay, but that is only when you have a cataract or not. Otherwise, you won't get anything. So what you can do, I will talk again in my lecture, in my talk. Okay, fine. Anything else? So you are waiting for the genetic test only, correct?
Yes, sir.
Okay, you can stop now. Mohit, if any comments you want to give, please give now. Otherwise, I'm going to give this brief talk to these people. I've been asked to give a talk at the end of this case presentation.
So I think if you look at the what are the clues from the history, I think it is very clear. This is a jaundiced baby.
Meanwhile,
45 days.
Alan, just stop the screen share as Dr. Mohit talks. Stop the screen share. Thank you.
Yeah.
Okay.
So this is a 45 days baby who's come with the jaundice with a high colored urine. There is a
Stop.
pigmented stools, right? So this is a neonatal cholestasis intrahepatic cause. That was our initial diagnosis based on the history, right?
Yes,
Then
sir.
you said there's a abdominal distension, probably due to organomegaly, we think it is. On the examination, you have confirmed organomegaly, right? There's no ascites.
No ascites.
No ascites, right? There's no history of blood and stool, so we have ruled out any coagulopathy.
Yes, sir.
right?
No.
And there was no recurrent similar sibling deaths also.
No, sir.
The baby was not sick,
No, sir.
right? This is all what we have got impression till now, clues from the history. And looking at this, a well thriving baby, intrahepatic cholestasis, onset of jaundice occurred initially. There was no significant family history. On examination, weight was good, your head circumference was good, there was no cataract, nothing, no abnormal facies, no edema, only hepatosplenomegaly. CNS wise, the baby was good, CVS and respiratory was all around. So we have come to the diagnosis of uh, your intrahepatic cause, and probably we ruled out everything. So we are looking into a metabolic causes. So
Yes.
what metabolic diseases are high up in your thinking now? In your presentation, what do you think are the metabolic diseases which should be 1, 2, 3, 4 like that? Can you tell me? Looking at everything in this aspect, can you just enumerate 1, 2, 3, 4? What are the intrahepatic causes, metabolic causes for
So the investigations or history and examination alone, sir.
whatever you want to use? Use all the renal issues.
So since the alpha fetoprotein is increased, we have done urine succinyl acetone, sir. That is also negative. So tyrosinemia is ruled out, sir.
Okay. So what, based on the history and this, you would have kept in your first DD in this case?
Sir,
Metabolic. But metabolic is a wide aspect.
metabolic process.
So what out of metabolic?
Sir, apart from tyrosinemia, type
What
4
else? What else have you ruled out from your investigations? Tyrosinemia gone, right? Galactosemia
sir,
gone or not?
yes, sir, ruled out.
Ruled out. Neonatal hemochromatosis
Ruled out, sir. Ruled out.
ruled out. Mitochondrial hepatopathies
Ruled out, sir.
ruled out. Storage disorders like Niemann-Pick and all.
We have to look for genetic studies, sir. We
So
haven't
you have to
ruled
look
out.
into, but was there a hepatosplenomegaly, or in fact it is a splenohepatomegaly which is commonly seen in your Niemann-Pick, right?
Okay, sir.
Isn't it?
Yes, sir. But here only hepatosplenomegaly.
Hepatosplenomegaly, that was also there, right? So you have now your investigations are entirely based on the genetic,
Yes, sir.
right?
And also PFIC also in our differential diagnosis.
PFIC, right. So would you like to do a liver biopsy at this point of a time rather than going into a genetic test? Would it help you?
Liver biopsy is invasive test, we have sent for genetic tests before, sir.
Would you like, because the genetic reports doesn't come so early, they'll take almost 3 weeks, 4 weeks to come. So would you like this child to suffer till then, or would
But
you like to do a liver biopsy? You will get
liver biopsy confirm the hepatitis, sir, but not gives the etiological diagnosis.
So what etiologies do you get a liver biopsies in the metabolic?
Bile duct paucity syndromes.
Right. And what else we are worried about?
Sir, in case of alpha antitrypsin deficiency, there is a
because there is no ascites we have seen in this case. So we are little relieved. Your answer should be this, that since we have not seen ascites in this case, because if there would have been ascites, we would have been thinking about the early onset cirrhosis, nodule formation, intracellular cholestasis, which is a poor prognostic factor for the baby. But since there was no ascites, that's why we are not going for a liver biopsy presently. There is nothing, no comment on the altered echo texture in your USG. So that was the one reason you are not going for a liver biopsy at present, and we would like to go for a genetic testing. But in case it would have been a little ascites, or we would have got any comment on USG, then we would have definitely done a liver biopsy first, alongside we would have sent the, because we would like to look at the early onset and cirrhosis and nodule formation, because that's worry, because otherwise your liver is gone. Right?
Okay.
So I think let us go over to sir. He wants to add something.
Okay, thank you. Let me start. Thank you, Mohit, for your suggestions. And so we just going to say something about prolonged cholestasis. Similar case as like your Ilan 40 days jaundice, high colored urine, white chalky stool. and then you're having just hepatomegaly. What's the possible diagnosis? We'll talk about all these things. So here, I want to all you guys always in the conjugated hyperbilirubinemia, by default, you think about this diagnosis biliary atresia. You rule out biliary atresia, then you look at anything else. So that's how you should be. Okay. You do not want to delay the diagnosis of biliary atresia. Okay. So it is approximately 1 in 2,000 live, 2,700 live births. It varies between different geographical area. So what is cholestasis? It is a reduced bile formation or flow, which basically lead to retention of bile. It could be many things, obstructive, non-obstructive. Okay, and most common thing is biliary atresia. Do not miss this. Any child, term baby, if they persisted to have jaundice after 2 weeks, or they're having in preterm more than 3 weeks, you take bilirubin, both total and direct. That is very important basic test. You have to do that. And anything conjugated bilirubin more than 1 milligram is abnormal, or if it is more than 20%, if it is the bilirubin is total is more than 5 milligram per deciliter. Very important. You document the stools. In exam, if you have a case, you write in the case sheet that you have seen the stool, or you write it there, sir, I did not have the stool to examine. Ideally, I wanted to see. So if you document that, we will know that you always wanted to see rather than just listening to the patient's story. So you have to refer to pediatric gastroenterologist for evaluation management because it's a complex scenario. You can, for the pathogenesis and cholestasis, I have written an article, you can read that one. So etiology-wise, I divide them as obstructive first. Don't miss the biliary atresia choledochal cyst. In your case, you did mention, Dr. Mohit did ask you about insipid bile. You also have to say a little more about perinatal nutrition. The baby was admitted, how long the baby had perinatal, etc. You need to say that. Then genetics is a big chunk now. We'll talk about that a little bit. And then the most important thing you should not miss is galactosemia and tyrosinemia. HFI is hereditary fructose intolerance, but it doesn't commonly present in this age group. It usually present on 4 or 5 months. You know why at 4 or 5 months? That's the time the weaning foods are introduced, and that is the time you introduce sucrose containing or fructose containing diet. If somebody give a pre-lacteal feed something else, then you might have introduced sugar, and that is the reason you may present. Otherwise, HFI, hereditary fructosemia is different from hereditary fructose intolerance. The enzyme is different. HFI usually manifest by 4 to 5 months when they started having weaning food, having some sort of fructose, sucrose containing diet. And the large group, the next group is hypothyroidism, hyperpituitary, endocrine, and then the sepsis. Never ever you should miss sepsis. And most importantly, in the neonatal period, the first 3 months of life, do not miss an HSV infection. Herpes virus infection is a killer. So you always, when you have a sick baby coming to you in the first 1 month or 3 months, start apart from starting antibiotics, start also acyclovir and do HSV PCR, wait for the report. If this negative, you stop it. Nothing wrong in starting acyclovir in this particular age group. Of course, you should not miss about any congestive hepatopathy is also a feature. So the salient features, as I mentioned earlier, dark urine, the diaper staining. That tells you it's conjugated hyperbiliary. You may have acolic stools, you may not have acolic stools. In early cases of biliary atresia, the stools may be fluctuating, it can be pigmented. That's the important thing, you need to know that. Sometimes if there is a response, there is a bleed there and there's a responding to vitamin K, there's a cholestasis. And you should think about the perinatal events, which we discussed during the case and as well as now earlier I mentioned to you. And important thing, the firm liver splenomegaly also tells you this is a very progressive disease sometimes. This could be a portal hypertension. Hepatosplenomegaly might indicate a storage disease or it might indicate a significant progressive liver disease with portal hypertension. That you need to think about it all the time. Stool color exam, that's the one I put in the top. Even before anthropometry, I put the stool color at the top. Anthropometry, you do look at the child, well or sick looking. We discussed about the facial features. Apart from allergy, you think about all the trisomies, you think about other things you think about. Eye examination, we mentioned about that. Always in between origin, always ask the ophthalmologist to look at the funda. It will give us an idea about the storage disease features like cherry red spot, etc. And skin phosphorus, particularly in a more than 3 or 4 month old child. Look for any evidence of chronic liver disease stigmata, particularly in an older child. Genitalia, we discussed about that. Look at the genitalia and look at for heart disease and look at the spleen and do not miss and serious examination. The importance of the stool color is what I am going to discuss the next differentiation, because that's the most important thing for the pediatrician. Don't think about anything else. If you are able to pick up a biliary atresia, you are a very successful pediatrician. Full stop. That's it. Okay. The top three, 1, 2, and 3, they are abnormal. The bottom 3 are normal colors. Okay. Even you can keep this in your clinic. You can show your ask your mummy, if they're unable to remember, just point which the nappy color, the stool color looks like, and they'll be able to tell you. This is a study done in Taiwan. Basically, they looked at a lot of their babies who were born consecutively. They looked at they at the part of the first immunization visit. They asked about this, the stool color, etc. They are able to pick up biliary atresia very early. The 3-month jaundice free rate post-Kasai, went up from 35% to 60%, which means 60% of the Kasai were very successful because they were able to pick up the problem earlier and they were able to do surgery very earlier. And also the 5-year survival rate increased up to 90% post-Kasai. And also, Dr. Nyacha is a renowned pediatric gastroenterologist in our country. His team has done a study about looking at the urine color and the stool color, something synonymous. There is an integrated urine and stool color is a major steps towards public health for early referral. You can take a photo of that. It's also available in Indian Pediatrics Journal. So ultrasound, I mentioned earlier, what are things you look at for? As Mohit mentioned, triangular card basically represents a fibrotic remnant of the portal tissue. That's what it is basically. The experienced pediatric sonologist will pick up, not every sonologist. So always get a pediatric sonologist to do that. And I mentioned earlier, what else you have to look for? I already asked you. Just because one important, remember, just because somebody sees a normal gallbladder does not mean there is no biliary atresia. Because in 1/3 of the children, they may have a syndromic biliary atresia. The rest of them are non-syndromic. Sometimes you may have, some sort of but doesn't mean that. Always put everything in toto. Okay, HIDA scan. Don't waste time in doing HIDA scan. Involve the pediatric gastroenterology earlier, because the failure of tracer excretion does not mean biliary atresia. In severe neonatal liver disease, due to even other causes, the liver may not take the tracer first of all. Only if the liver uptake the tracer, then only the tracer can get excreted. If the liver fails to take the tracer, you may not see an excretion, and that does not mean it is biliary atresia. However, if you see the dye in the intestine, it rules out biliary atresia. But having said that, we do not recommend doing HIDA scan nowadays. Liver biopsy is very useful. It is useful in your case also, if you ask me, because as Mohit mentioned, it tells me the chronicity of the disease also, because the splenomegaly is there. I want to know whether this is a progressive liver disease. If you're thinking about tyrosinemia, I want to see what's happening in the liver structure, everything. But I want to do this because in your case, there is no coagulopathy. So it's a safe thing to do for me. I would do that before doing a genetic test. So in biliary atresia, I look for particularly for portal bile plugs, look for portal tracts, expanded portal tracts with bile duct proliferation and periportal fibrosis. This is what I'm telling you. You look at all these features in biliary atresia. If a child comes to you like 45 days, involve us very early so that we will be making sure this is biliary atresia. Before refer to pediatric surgeon, you should always involve pediatric gastroenterologist, because we have had cases of Alagille syndrome who was underwent Kasai procedure. So we have to make sure we rule out all the important diseases before we conclusively say this is biliary atresia. If you do before 60 days Kasai, which is hepatic portal enterostomy, 70% you will be able to establish bile flow. After 90 days, it decreases significantly to less than 25%. So if it's an unsuccessful Kasai, they go for liver transplant, or the delayed presentation more than 3 months with ascites or more than 4 months, they have to have primary liver transplant. I talked about only biliary atresia. That is a very important disease for you to know that. I'm going to talk about a bit of progressive familial intrahepatic cholestasis. Primarily, I want to talk about low gamma GT. Why gamma GT is relevant? Usually in biliary atresia or in Alagille syndrome, it will be very high. Whereas in certain PFIC, it will be low. Like PFIC1 and PFIC2, it's typically low or low normal. Even if it is a lower range of normal, it is low when there is a cholestasis. That you have to remember that. So it's basically is happening because of defect in bile acid synthesis or conjugation, or there's an abnormalities of contact. The varying spectrum. Okay, main thing I wanted is PFIC1, PFIC2, PFIC3. PFIC1, PFIC2 is bile salt transport defect, and PFIC3 is MDR3, usually present bit later age group. Sometimes they can present earlier. And there are other types out there, type 4, type 5, type 6. Forget about them. We will deal with them. If we have a low gamma GT cholestasis or low normal gamma GT cholestasis, and then there is a pigmented stools and direct hyperbilirubinemia, one have to think about PFIC. First 2, 3 types, 4, 5, 6, I'm not going to talk because they are going to be very, complicated to talk. So first one, type 1, they can have, apart from the involvement of liver, they can have extra hepatic involvement, like involvement of intestine, diarrhea, they can have hearing loss. And PFIC2, usually they do not have. And PFIC3, I mentioned, they involve very late. But they can also have a neonatal presentation. So these are type 1 and type 2 will have low gamma GT, whereas type 3 will have high gamma GT, as like biliary atresia or Alagille syndrome. So Dr. Mohit kept on asking you, what are the pointers for metabolic liver disease? So I'm just going to give one slide for that. Consanguinity, abortions, previous sibling death, or the onset of the symptom as soon as you introduce the feeds. That's very important. They could have a diarrhea, recurrent vomiting, hypoglycemia, acidosis, ammonia level increased, or they can have a recurrent episodes during the catabolic stress. They could have seizures. They could have developmental delay, hypotonia, cataract in galactosemia. They could have renal involvement, particularly in tyrosinemia, or even in hereditary fructose intolerance. What we do is when we do a urine organic acids, we also even amino aciduria, we can check it. That will tell you about involvement of renal tubules. And then sometimes in metabolic liver disease, particularly in tyrosinemia, the coagulopathy is very, very significant compared to even jaundice or compared to rising of gamma GT or ASTLT. And sometimes the aversion to sugars may point towards hereditary fructose intolerance, or aversion to proteins will point towards urea cycle defects. I already gave a broad headings about various etiologies. Again, I want you guys to take this photo of this slide. I do not want any of these trainees to miss this one differential diagnosis when you present your case in exam. Do not miss biliary atresia and gallocolidoculsis as obstructive type. Do not miss sepsis in any presentation, and also think about UTI. If somebody says any particular sepsis you do not want to miss, viral thing, herpes, I don't want to miss. It carries a high mortality of 50 to 60% if you don't treat early. Metabolic disease, do not miss galactosemia, do not miss tyrosinemia, particularly newborn period, HFA later on. You cannot miss hypothyroidism. You can miss hypopituitarism, but you cannot miss hypothyroidism. Other things we had discussed about that. Gestational alloimmune liver disease is the new terminology for the old terminology, neonatal hemochromatosis. People have to know this one. Okay. So cholestasis, you do examination, bile, look at bilirubin, look at the stool, ultrasound, everything. Look at the gamma GT. Is it low or is it normal? If it is low, is there a pruritus? The pruritus is high, it could be PFIC1 or 2, or it could be, when there's an elevated serum bile acids, it points toward PFIC. If it is low bile acids, it points towards bile acid synthetic defects, which is BASD. Or if it is extra hepatic, it could be, one of the biliary atresia could be there. Or if it is the gamma GT high, as I mentioned earlier, it could be PFIC3. It could be alpha-1 antitrypsin deficiency. Do not think in Indian children. Some of the seniors will not act like if you say alpha-1 antitrypsin, because extensive studies has been done in India. Alpha-1 antitrypsin is not being found in our population deficiency. It's much more common in Western population. Yes, Alagille you can think about. If the gamma GT is high, if this pruritus is not there, it could be something else also like CF or citrin deficiency. So to summarize, this is algorithm for you. If there is a neonatal cholestasis, is it a pigmentous stool or is it a colic stool or a fluctuating stool color? Think about biliary atresia or choledochal cyst or other things. If it is pigmentous stools, is this child well or sick? The child is well, think about hypothyroidism, think about PFIC, progressive familial intrahepatic cholestasis. The child is sick, make sure you rule out infection, even if the child is well. For me, the child is well, also look for UTI. Do not miss UTI even in a well-looking child. If there's a decompensation, likely to be metabolic liver disease, more likely galactosemia, tyrosinemia in this newborn period. A bit later on is hereditary fructose intolerance. Think about hypopituitarism if there is a midline defect. So my key message for you all is early detection of biliary atresia is key. If you miss that, you will be failed in your exams. And then get a detailed history for metabolic liver disease. Look for dysmorphic faces in your examination. Look for associated congenital heart disease. Always evaluate gamma GT as part of LFT. Make sure whenever you do LFT, always check prothrombin time. If it is high, it points towards acute liver failure. Give you a dose of vitamin K. Repeat after 12 hours. If it is still high, do not keep the child with you. Refer to a pediatric gastroenterologist. Since sick children rule out sepsis, even in well children, think about sepsis. Do not miss sepsis. And do not miss treatable causes like sepsis, UTI, biliary atresia, choledochal cyst, galactosemia, tyrosinemia, hypothyroidism, hypopituitarism. That's the thing. If any query, you can contact me on my email or my mobile number. Thank you very much. I finished in 14 minutes, Shiva.
Excellent presentation, sir. I think sir has given in a nutshell everything, whatever is required.
Thank you, Mohit. And any questions or anyone or any comments from any seniors, you can please do let us know.
Thank you, Dr. Chu, for a very wonderful.
One question I would like to ask the presenters is like how early you can diagnose biliary atresia. Presenters, are you listening? How early you can
You are
diagnose?
not finished yet. Do you think he's asking me? He's asking you. Ilan Doctor is asking how early biliary atresia.
Why we are not able to diagnose it early? Can you just tell me why there is a delay? Why?
So the child, it is a dynamic process, sir. Since the child is, the child will be having pale stools at a later age, where the bile duct is fully obstructed.
No. It is the conjugated bilirubin starts rising itself on day 1 or day 2 of life, but the peak of it occurs usually after 1 week. It's around 2 weeks. That's the time when the peak of conjugated bilirubin starts occurring, and that's the time. Otherwise, still 14-15 days, the parents think the baby is absolutely all right. But there's one literature that says that the life starts at birth. What does it tell you? That if you do a direct bilirubin, that is a newborn screening, less than 24 hours of life. It was done with the children with the biliary atresia and the control ones. It was said that the direct bilirubin was 0.98 plus minus some 0.15 mg per dl. And in 24 to 48 hours of life, it was 1.4 of a direct bilirubin as compared to just 0.19 of the control. So this is a very good one of the papers which says that the life starts at birth, newborn screening. This is very crucial, but usually we don't do it in India. But that's also one of the papers which has been published, I think 2021 in Journal of, and even ILBS has also contributed to that. So I think that's very important. You should keep in mind direct bilirubin is very important. Most of the time people get only total bilirubin, they don't have a direct bilirubin. Many reports we see, especially in the peripheries, in the villages, they come only with the total bilirubin. They are not bothered. So direct bilirubin is very important. Staining of diaper very important. As MS sir has emphasized, everything that should be seen into. So what was the diagnosis of your case quickly? What was your diagnosis based on genetical test?
So diagnosis is not yet come, sir.
What was the gamma GT in your case? Gamma GT?
Normal.
What is the value I want?
54, sir.
Okay, thank you.
Okay, so let us know what the diagnosis you arrive later.
But I tell you honestly, Mohit, as
Yeah.
you mentioned earlier, in these sort of cases, I would definitely do a liver biopsy.
Definitely, it should be
Because,
done. It should have been done.
it gives me a lot of clue. It just gives me a clue.
That's what I said before.
Rather
Along
than,
with the
I tell you
genetics.
honestly, guys, I tell you
Yeah.
honestly, genetics do last. Do not
Absolutely.
start because it confuses a lot of time, especially when we get this all the strange reports, it confuses. Go structured way, definitely do genetics, but try to narrow down the diagnosis before you do that. Genetics should not come first.
Absolutely.
Unless the child is very sick, coagulopathy, that's different scenario.
Yeah, absolutely true. That's what I said. Liver biopsy is very important diagnostic tool. So I think conclude up to
Thank you,
the
thank you, Dr. Mohit and Dr. Vishwanathan. Any comments from Dr. Sivagunathan before the
Sir, it was very nice discussion, sir. So we are also waiting for a genetic study, sir. Sir, is there any novel marker like matrix metalloprotein 7 in a serum which indicate biliary atresia? Is it so, sir? Is it available in India?
Please go ahead. Please repeat.
Matrix metalloprotein 7 in a serum.
I don't know it's carried out in India, but it is
Yeah.
there in the news. Definitely, it's in the literature. It
Yeah,
does work, but in
MMP7,
India,
that's what we call as metalloprotein. Yes,
yeah,
it's been done. It's been done in certain centers in US on the regular side.
US
And
itself.
there is a research project going on in India. We might know the results in probably in few years' time. Yes, it can be done. It has got some relevance in that, but we have to wait for some time in our country. But definitely, it's been as part of a program. They do that in United States. Yeah. Good case. Nicely, not too much of information, very relevant information you have given, and you have prepared very well, Ilandandral. And who's other person? Sorry, I forgot your name. Ilandandral, other one?
Sangeeta.
Thank you, Sangeeta. You all presented very well. You answered most of the questions very well. And thank you, Dr. Siva, for giving a good case. Simple, straightforward case. The only thing is you should mention this tool examination as part of your exam. You have to document that. That's very important.
Thank you.
Excellent
Thank you very
presentation.
much.
Congratulations to both of you.
Thank you, sir.
Thank you, Mohit, for all your good discussion points, very important point, relevant point, and thanks for joining. Good to see you.
Thank you, sir. Thank you. Same here, sir.
Thank you very much, Dr. Mustri, Dr. Sivagunathan, and Dr. Mohit, and of course to the postgraduates. We had a wonderful session today, and I think we all enjoyed it, and it was quite a learning experience, not only just for postgraduates, even for practitioners. So thank you very much, and hope to see you.
Thank you, Thiru. Thank you, Thiru, and IIPTNS team.
Thank you,
and thank you very much. Thank you for coordinating very well. Thank you very much.
Bye-bye. Thank you. Good night.
Good night.